I'm looking at the symptoms, and he starts to resolve. And so I'm looking at him, I'm talking to him, I'm thinking, he's having a stroke, we need to get him to the hospital. Now I have to deal with him coming out of this, saying, no, you're not taking me, no, I said, okay, then I'm gonna call the doctor. So I called his doctor. Doctor's office should have said, take him to the hospital, because that would have been a direct line from his doctor bypassing me, saying, you need to go to the hospital. Instead, they make him an appointment 2 hours later to come in to be seen. Okay, so my failure, their failure. We get him in the car, I said, I'm either gonna call you an ambulance or we're gonna go to your doctor's office. So now, the closest hospital, 5 minutes from us. We're driving up to Folsom, 35 minutes from us, and the doctor sees him and says, I suspect that he might be having a stroke. This is not normal. I'm calling the hospital. We go to the hospital. Boom, the stroke squad is there. They pulled him in. They did everything that everybody talks about, but we lost nearly 4 hours of time. Now, he didn't have a stroke. He had a TIA or a TGA. We are still not quite sure about that. But the fact is, I'm an educated consumer and I failed. And I shouldn't have failed. I should have insisted, picked up the phone and called 911. That'll never happen again. But it could happen and I could have lost my husband. So no matter how well educated, when we're actually faced with a crisis, it's how our behavior changes and what mode we go into from that point. So I think this is such an important discussion to have and how we can really reach out and do some great things in the community.
And I think that, what I find really interesting about it is that it's, psychology and cognitive psychology is really advancing, and to be able to use some of the learnings that we've had over the years about what really influences behavior in these kind of situations, I think is going to be really exciting. And so, and I actually, I totally get it as a physician. When we're faced with uncertainty, as patients, when we're faced with uncertainty and fear, and then also shame, like, oh, I don't want to activate 911, maybe it's nothing. So all of those things come into play, and it makes it more random than it should be. So, thank you.
But I think unfortunately in a situation like that, and I do respect your point, Liz, is that a lot of times people have the capacity and are saying no. We deal with it a lot within is that, when you have a person who has capacity and saying no, then it's very difficult to get the physician or the physician's office to kind of make a difference and say, hey, come in anyway. It's really a difficult situation, but I do think it's really one of the key issues is the education piece, because I think so many people say no because they may be slightly educated, but quite, and they're looking for that, that it's called denial, right? And so the denial piece is denial. You rationalize it because of denial, and so the issue is how do we get to it? And really, it's about educating people to the best extent possible.
Well, I think what we're hearing too, it's about education of providers as well. Because a story I've never told here before is a Kaiser nurse, 35 years old, sister of my brother-in-law, said, I'm having a stroke. She was an ER nurse, and nobody believed her because she was 35.
Right.
She died.
Oh. I'm going to take one more question, and then I want to quickly get to the California Challenge so that you guys know the other side of the work that we're doing.
I agree with everybody that, that call 911. Of course, if you're in urban areas, it works. The treating it as an emergency of red alert, that's great, and especially if you're in the rural areas, if you're farm workers, if you're out in the fields. In the fields, there are so many rural areas that do not receive a signal. They are completely signalless, it's happened where farm workers have been trying to call and there's absolutely no connection to 911. that needs to be researched. More studies need to be done about how to get farm workers to treatment so they don't die, because that's what has happened.
I think that's a great point, and it actually leads into the next section of the talk, which I know we only have a couple of minutes, so I'll go through it quickly. But the second piece of the puzzle, so the first part is decision delay, and the second part has to do with the stroke system of care. So really creating a system of care that as quickly as possible, once the patient identifies and activates the emergency system, assuming that they can, that patient gets as quickly as possible to the definitive treatment. So we already talked about the Helsinki model, and the reason we're saying that we want California to be a high-value exemplar is we'd love to get the whole state of California, even these areas, where we can actually be the most efficient in the world for treating stroke. And as Dr. Klingman said, there's a very clear bundle that needs to happen that involves pre-hospital stroke management and communication via EMS and an efficient hospital pathway. And we're developing these bright spots around the state. People are really understanding how to do this efficient pathway. There are EMS agencies that have this optimized the pre-hospital stroke management. And so we're really on the cusp. And then we have a bunch of players in California that are now really poised to actually take California from where we are today to the highest performing, the highest performer in the world around acute stroke care. And so at CERC, we've been really thinking about how can we get this high velocity bundle implemented in California. And so we have a strategy that we've devised, and we'd really like to, and we've got a bunch of partners on board, and we are working to try to launch 1 to 2 regional learning collaboratives where we leverage like Dr. Klingman and others who are doing this kind of rapid, efficient hospital work, and where we bring together not just the hospitals, but the EMS agencies, pharmacies, consumers, and other stakeholders in really driving efficient stroke care at the regional level. And the reason we think this needs to happen at the regional level is because that's how our emergency response system is organized in California. And so it's going to look different in a rural area than in an urban area. And so just as Dr. Klingman described when he spread his practice from the early adopter hospitals to the other hospitals, these regional LEMSAs really need to solve the problems that exist in their own areas because it's not uniform across California. The other thing that we think is important is really motivating participation with key influencers. And this is one of our sweet spots at CERC. Arnie's worked for many years with employers in this, across the country actually to improve care quality. And what we'd like to do is bring employers and other key influencers together. The Right Care Initiative, the American Heart Association, the California Department of Public Health, the EMSA, and our employers and businesses within our region to actually motivate EMS, hospital, and consumers to do this work. And then we believe that after launching some collaboratives and understanding how we can really create high performance across our region, not just in one hospital or one EMS agency, but across all of the providers and hospitals, we'd like to accelerate that adoption across the state. So this is just an example of the Paul Coverdell Stroke Program is one of our partners. And the most exciting thing that's happening in California right now is this stroke program. The Coverdell program is partnering with EMSA to create a data infrastructure that will allow process data to be collected at the EMS provider and hospital level and linked together. They're also collaborating with the American Heart Association on this registry and this work. And we believe that this registry can actually be used as sort of the underpinnings of improving the stroke response, acute stroke response in California. And I think Janet is here today. Janet Bates is here from CDPH, and she knows a lot more about this than we do. But what we'd really like to do is, what we think is different and new about this, and Terry will resonate with this because it's similar to his work, but it's really pulling all the partners together to work together on quality and reducing the time from onset of stroke to getting a definitive treatment. And so I'm not going to go through the rest of this, just to say that there is evidence that these kinds of collaboratives can reduce door-to-needle time and spread best practice. I believe that we need sort of quality improvement collaborative 2.0. And so really thinking about how do we involve process engineers for this sort of engineering heavy piece, which is the hospital piece. And how do we use the new data infrastructure that everybody wants but is often hard to do? And then how do we maximize the power of the network and to spread these best practices? So with that being said, there have been so many people who have contributed to this work. We have our original high-value stroke care team. We have a team at CERC. Actually, Ramya Pratiwadi is here today. She's our research staff on the project. Hattie has been incredibly supportive and actually getting us moving on this work and connecting us. And then Genentech has been very supportive. Actually, they are supporting the Stroke Drills project, and then they really helped us grow our network. And they did support some of the planning for this work. The Coverdell Stroke Program has been very generous and kind with us because we want to help California move, but there's so many different stakeholders, and we really need to learn from all of you how to do this best. And the American Heart Association and Ralph's Pharmacy, and we'd like to add more to the list. So we're just, it's amazing. When I first started this project, I was, it just seemed like an idea. And then Arnie's sort of pushing on, it's like, oh, we're gonna get door-to-needle time in California under 20 minutes. And I was like, really? Do we have what? And now, and then Genentech supported us, and Hattie has supported us, and CDPH has supported this effort, and they're doing their own independent effort, and now it really is a dream sort of slowly turning into reality. So thank you so much for your time, and I know we're out of time, so I can take questions afterwards.
Going to be in this room at 12:30 instead of 12 o'clock. So lunch will be served at 12, and then the meeting will be from 12:30 to 2 o'clock, and that will be on March 14th. So what we're doing prior is a private data group among the groups that do a data sharing agreement. So we're trying to take it to another level for the medical directors of the delivery systems. And so those delivery systems will be meeting at 12:45. 11:45, thank you. So that we can try to get more concrete progress across the health systems on our intermediate prevention measures and other planning through data. So thank you so much for an absolutely amazing program. And Dr. Revelo, yes.
We were providing CMEs for this. Unfortunately, there's been a little glitch. We're in the process of trying to identify another CME sponsor. But if you have any ideas, we'd love to get your ideas, because this is clearly an important piece that we want to provide going forward. But unfortunately for this meeting, we are not able to provide CMEs, but hopefully we can have something going for next meeting.
We're working with UC Davis to solve the problem. Hopefully that will be how we end up bringing CME back. But if you do have ideas, this is a really concrete, practical thing that we need help with right now. So thank you for bringing that up. And everybody have a wonderful Valentine's Day. Take good care of your hearts and your families, and we'll see you in a month.